Well, thanks for coming in today. We're looking forward to talking to you. This is Parkinson's Journey. This is a new program we started this year. I'm John Dean. I'm a speech language pathologist specializing in Parkinson's. I'm joined here by the lovely Josefa Domingos, a physiotherapist here in Portugal.
So we are here today to try to, I would say, reflect and share some ideas about something that obviously has an impact on Parkinson in a significant way. So I will start off by saying why we chose this title. So the reason why we thought about this is it is very common that in a clinical setting, independently of the professional, you can hear things like, do you worry about form? So it's a common question, might have different twists, but in standard tests, we tend to triage this problem in Parkinson. And independently about how the person answers, so imagine the person answers, no, I'm not worried about form. It is important for us to think about the impact of these questions. When professionals ask certain questions and the list of symptoms is usually enormous, I think it will be very common for the person to think about, okay, will I have that problem? So this is where we want to start our conversation is, what are people thinking about when they are confronted with constant input about form in Parkinson? And specifically because obviously it is a topic that might induce some fear. And this is what I want to discuss today, is really think about, should we be reinforcing that people with Parkinson and their care partners should be worrying about form? And we want to look at this question in two ways. We want to look at from the patient and the partner perspective. And for this, we have used the questionnaires that most of you have answered, and to which I really appreciate it, because it really gives us an insight about what you are really dealing with. And then we will also, just complement this question with a professional perspective of why we should or should not worry about falling. We will then focus on, okay, so if we get to a conclusion, yes or no, what can we do to reduce the risk will be the second part of our talk. So let's focus on, thank you,
Thanks.
From the patient the person living with Parkinson and the care partners at the perspectives that you shared with us. When we asked everyone, do you believe that people with Parkinson should worry about falling? These were the results that we obtained. So what we can see is no one felt strongly about saying no, but we did have significant response, and we had about 68% of the people said yes, and then some were divided on depends. So I want to share with you some of the results and why people answered what they did. So when we think about people that answered yes, I think people should be worrying about falling. One of the answers was that Parkinson is a progressive movement disorder. So this is why we should worry. We should also worry because it seems to happen a lot. I feel unsteady and not balanced when I move. Another person shared having concerns about something keeps me more aware of what I'm doing. When we think about opinions on depends, we had people that were answering, okay, every case is different. That's why it depends. It depends also because it can happen so fast when you're least expecting it to happen. And also my falls have not been caused by balance issues yet. So here a focus on balance has been the main cause of falls. I do know that people tend to really like to explore what others are thinking about the problem, so I did put some more in. So more people that answered yes shared with us that people should prepare themselves for this malady. With my severe osteoporosis, falling could be disastrous, so here's a perception of a greater risk. Well, guess the words. Be aware of risk and how to avoid a fall would be also important, that's why, yes. So yes, balance is part of the disease, and to keep safe as long as possible, we need to also worry. If we think about more of people that answered depends, it depends because we are snowflakes, it depends because individuals vary in what Parkinson's symptoms manifest, and also because everyone is unique. And then we have depends on their balance as well. Remember, we mixed a lot of different input, and we had more people that said, Okay, so yes, because people need to be awareness, and because falls are likely. Also, a fall can have a huge impact on your life because a fall can result in injury that can put you out of commission. Remember, these are all words coming from you, and because if you don't, you may die. So, of course, this last one is particularly strong, as you can imagine. Now, with some more comments on depending, what people said were individuals vary in what PD symptoms manifest, so keeping in line with the same previous thought about how unique everyone is. And then depends because we should be aware of the risk, but not obsess. And I think this is a nice key message. And then finally, not worry exactly, but be aware and do something to help prevent falling. Okay, so we're transitioning. That's why it depends. Now let's think from a professional perspective. What we tend to promote is something like, okay, can we do ask the question, so we are guilty of asking the question. It's just one way for us to be able to perceive if there is a real impact of the formula. That's why we use the word. But truly what we are aiming for is to get people away from the word of worrying. And this thinking of, can we shift this concern that exists to make people aware that unfortunately, Parkinson's disease is recognized as an increased fall risk. So people with Parkinson tend to fall more, and they tend to have more frequent falls as well, as I mentioned before. This is something that is important for the person to know, but it should be something that leads us to action. So that's the first thing that I would say to someone that is falling and we are assessing. But the second thing that I would say is, like, can we maybe ask ourselves better questions? So, and transitioning the way we think about what is happening will help us deal better with it, if you all agree. So questions like, how can I stay safe without living in fear? What are my early signs or warning signs? And I'll say early can be even if we are falling. How can I recognize what are situations where I uniquely am in danger, right? And then obviously with a clear focus on what can I do about it. I think this is where professionals try to be positive and focus on what we can do. Sometimes when we do hear a lot of talks specifically on topics like this, I would say that it's more that I see it might have a negative impact if we spend most of the talk spending about trying to convince you how much impact falls can have. And by this, I say that I will not go into depth of characterizing the falls, but I do want key messages for you. And one of them is this, that worrying can obviously potentially lead to something which is a new symptom or another symptom, which is fear of falling. And this one has been highly studied in Parkinson's disease, and it is related to, imagine, people that have been identified that have like walking difficulties, that have more dependency in daily activities, that might have more fatigue, that might have more balance issues or door cast difficulties doing two activities at once, and also changes in gait speed. So these are the characteristics of people that might develop most fear of falling. What I'm sharing with you is this is a topic on its own, and it's very important for us to be able to identify it so that we do not, I would say, promote it as well. So indirectly, if professionals are all talking about this, in the way we have a responsibility by when we do talk about topics that might be more challenging for us, like dyskinesia, swallowing, or that we must find a way to be able to talk truly about the problems without increasing the fear. And so I want to share with you why this might be so relevant is one of our colleagues and friends that published this research and actually looked into how this might impact behavior. And let me break this down in a more practical way. So let us imagine we have someone that had a fall, and several things can happen. Let's think about it. So one, the person falls, but he does not develop a fear of falling. And that means that he gets up and he just resumes his normal activity and doesn't think about it anymore. So that's one reaction that we can have. Or I may fall, I might get up, but I might think about it and so develop some sort or a somewhat fear of falling, but that doesn't really have an impact about how I change my daily routines. Okay, so these are two possible scenarios. And these are the people that we will classify as non-avoiders. Then on the other side, we might have someone that falls, and this person has a more negative experience or perceives it as more negative and develops the fear of falling to the point that the person will avoid certain activities. Now, what can happen, and this is who we call avoiders, classifications just for us to be able to think about this problem. Two situations that can happen. So either this fear of falling may actually be useful because it will help us be more aware of situations that might place me at risk. And so that means that I will be able to not repeat that situation in particular. I always tell the people I work with, it's okay to fall once in one place. But if you repeat exactly the same fall, it's a pity because that means you did not learn anything from it. So I emphasize this, what did we learn from the fall instead of focusing on, the negativity of the fact of a fall. Another response is, so the person, the fear of falling may be so impactful that it actually starts what we call a vicious cycle of disconditioning, which means the person's confidence is compromised, the person starts avoiding more being able to be active. So these are the people that would, for example, spend less time in standing position because obviously you're avoiding any situation that might place you at risk or that you perceive the risk. So as you can see, this avoidance behavior is actually being even further researched, and it's interesting to see then it's either classified as is it appropriate or is it inappropriate. And this is intriguing because that means that we have at least 4 categories or profiles where people might fit in, and that means that we have to think about treatments very specific to these groups. So if I have someone that I would say inappropriate non-users. So it's someone that avoids, that falls, that does not emerge, has difficulties in his gait and his balance. He falls frequently, but he does not perceive, does not accept the risk, and so that means he's always falling even more because he's not appropriately learning from it. Now, what's interesting about the challenge to treat such a person is how can I change behavior if I cannot get that person to understand that there's a risk? These are situations that I would say the extremes, which is very challenging, especially for the families. And it can be mostly linked to some components of Parkinsonism, so some of the diseases that are related to Parkinson, where we have the difficulty to perceive the danger and the incapacity. Now let's see, on the other hand, if we have someone that is, imagine fearing everything. So that will be inappropriate avoidance. Someone that actually has good balance and good gait, but the person perceives that anything I do, I place myself in danger. And I did want to give you an example of it. This is a lovely woman that I work with, and you will see she has what we call freezing of gait, severe freezing of gait, and it's related to the fear of falling. And freezing of gait is the sensation that your feet are like glued to the floor. This is how it is described by people with Parkinson. What is interesting is so the person perceives that she's unable to walk and everything, so she has to be close to the objects when we're walking. The way that I would treat this woman would be completely different if I had a different profile. And let me just show you something. This is something amazing. He or she is walking up and down quite well. So there's almost the freezing is just only in turning. And what is fascinating about this is because I actually created an activity that distracted her cognitively from her perception of fear. So, and I know she really likes games. And this type of activity where she has to remember where she has the cards, she's so focused in the, I would say, game exercise, that her freezing and walking is actually quite good. So we have to be able to find ways to be able to, our mind is a very interesting thing. How can we distract our mind from that fear so that we can actually get some good training? Okay, so just to share that the way we would look at someone with certain behavior versus another will have to influence what and how we train. And the final message here is really that I think everyone will agree that fear can obviously protect us and it serves a purpose, but too much fear obviously will also limit us. So if everything's okay, then in the chat, we will go to our second part. And this is what, okay, so we identify that there is obviously a risk and that we want to focus on solutions. And so I will think about 3 different ways that we can approach this. This is a complex subject and we can treat it, we have limited time, but let me give you key ideas. I think the most important way that we can reduce risk is by not ignoring it, right? But at the same time, the more I understand it, the less it will bring on fear, the more control I will feel over it. So I think if we think about extreme situations, which is waiting until a fall happens before we address it. Obviously, now people have access to a lot of information, a lot of educational content. You all here, so you obviously clearly people that are different, that are looking for that information. So I don't think this will be a major issue, but it's more reality than you think. And then the other extreme is like, okay, so how can I make sure that I don't become too afraid of falling, that it's actually having a negative impact? See? And the key questions that you probably want to reflect on is, how does thinking or talking about falling make you feel, right? Or how does fear affect your confidence or your independence even in social life? So socializing, maybe people are going out less because they don't feel so confident. So does this fear ever stop you from doing something you enjoy? So I think these are questions that we'll leave for you to think about, and a way for you to triage if maybe this fear of falling is becoming more impactful. We did ask in the questionnaires, and just to get a general idea of what people were perceiving about what does this fear and was thinking about falling make me avoid. So most of the answers were clearly, walking outdoors. People might perceive more risks outdoor than indoors, and curious enough, there are more commonly falls inside the home than outside in Parkinson. And I would probably link this to the fact that inside the house, we probably are less attentive to the risks, and because we are more, focusing on what we're going to do. I'm going to get out of the couch and I'm going to go answer the phone or something. So there might be a tendency for more, less attention to movement.
Probably like, how do you have the most highest likelihood of having a car wreck within a couple miles of your house? You're more familiar, so you turn off your radar a little bit more. You're not quite as attentive.
Yeah. I would have situations where care partners would be wanting to go with a person, for example, to go drink coffee. But the perception that I get is when the person goes alone, so the person with Parkinson is going alone, he is actually more attentive. So he tends to fall less than actually when he's with someone. And that's also an interesting phenomenon to think about things that might provoke the falls. So getting out of bed and chairs, and that means transfers. That's again is when we're changing movement patterns, and there's all sorts of factors that will influence that can be obviously treated, and we'll touch upon that in terms of what strategies to use. The second key message for us to how can we manage the risk is to learn to recognize, early signs, risks, fall risks in general, and maybe just understanding if they are increasing and how to report it. So when I think about, accompanying people throughout their journey and what makes sense, and about, so now am I going to be self-assessing all the time? No, I mean, that's why you have the health professionals, and they will obviously guide you in this process. I think what we have to get is to a place where we are comfortably talking about potential problems and that you are sure that you are doing everything that you can to fight against them. And so being able to perceive the following, feeling unsteady when turning or walking through doorways seems to be an early sign. And you might already, this doesn't have to be with, doesn't have to do with the time of diagnosis. So it's like, because people fluctuate a lot throughout the Parkinson disease, right? So you have moments where you might feel better or worse. And so understanding when are there moments where I might be feeling worse, if I'm feeling slower, if I'm relying more on furniture or walls around me, if suddenly I'm meeting friends and I'm talking within a standing position and for some reason I find myself trying to get to a wall as quickly as possible or getting even more tired if I'm in the standing position. The most classical one, which would be experiencing this freezing, this feet getting stuck to the floor and being unable to take a quick decision on which foot comes next, is very related to the fear itself.
This video is him at different times on medications. Is that right?
It's interesting.
It's interesting. So
it's throughout the whole day, and he's filming how he changes throughout the day. And I think it also reflects a lot changes throughout the whole disease as well. So that's why I think it's a fascinating video to show this. Professionals will mostly focus on asking you about if you are worried about falling or if you had a fall. So it's more about the history of falling, which is something that you might more frequently hear in the clinic. Okay, so what I want to also share with you is just ways that if you feel that you want to identify exactly where it is impacting this concern, this worrying about the falling, there are several ways for us to assess. And these are just 3 examples, but so falls efficacy scale, I'm sure you've had therapists we approach you and ask you, how confident are you that you will not lose your balance when you come to and you've got 1, 2, 3, 4, you've got different options. The relevance of these type of tools is interesting if you share it with your professionals so that they can imagine someone here selects getting in and out of a car. That means if I see that this is the main issue, I will probably create treatment focusing on that fear, on that circumstance. So that's why I find them particularly useful. The most useful one, if you are dealing with falls, is to really be able to have a diary. And we might underuse these, but they are very useful tools to help us get to solutions. That's why I like them. Specifically, the one where it will characterize, the circumstances. What were you doing before you fell? Did you fall forward? Did you fall backwards? Did you have anything in your hands? Were you talking with anyone? Were you thinking about anything? Because it's those circumstances that will help us and lead us to plan better interventions for you. I wanted to share with you that there was a question that we placed, which was, when did falling first become something you paid attention to? That goes in line with the messages from this talk is people are aware that there's a risk. Everyone seems to talk about falling and Parkinson. And so when did this first call your attention? And some people, I just shared some of the responses. And so early on, since diagnosed, after I fell the first time, around the time I was diagnosed, I had fallen a few times before and I got to see a movement disorder neurologist. So we have a different, and I think I'm just going to highlight this one. I was made more aware when several different practitioners mentioned it. My cardiologist mentioned it in relation to blood thinners, my physical therapist person as related to gait, and my neurologist as related to medication. So various people noticed it, but from different perspectives. So there's a message there, I think. I found this very interesting because when we ask questions about the falling, I think as a health professional, it makes me think that we always have to complement it with key messages. The reason why I'm asking you this question is because of A, B, C, D, and E. I'm not giving you the A, B, C is specific to that person. So it's very interesting to understand the person that's in front of me and the reason why I'm asking that question. So I think the third key message was to build confidence through a guided strategy, which means really have a plan for it. And that came to this question, which is, have any professionals ever discussed fall prevention or treatment options with you? So since they're asking so much about falls, they should also include, why not discuss this as a plan, right? So most people said they had some contact and some discussion on it, which is good. And I want to share with you, so if I have someone that's starting to fall, this is how I look at it, and this is how I try to organize our strategy of intervention. Being very fortunate to have most of the time endless sessions with the people that I treat. So I don't have, like if I had only one session, I would have to have a different plan. And so this is important, the time that we have with the professionals and how they can really help us. And so what I would discuss with the person was, okay, let's try to recognize what are common factors for falls in Parkinson if the person is, imagine, not falling. But if the person was falling, let's try to identify things that were very specific to that person, right? And now this is, I would say, one of the slides that probably is the most scariest, because this is the list of all the risk factors for falls in Parkinson. I'll give you a few seconds to just look through it. It's long. It's obviously we have, as we age, we have several there on the left that obviously will place us at risk of falling. It's not a problem unique to Parkinson. It's part of aging as well. And then we have things that are very specific to Parkinson, and that's all the rigidity, especially around the trunk. We have the cognitive challenges as well, the severity as it progresses. As I told you before, the fall history is usually a key element for identifying. And here on the top 5, you actually have dual tasking as well. And one of the motives that really led me to dive into that area specifically is because I see the impact it has on falls and being one of the most frequent causes of falling. I'll come back to that. But as you can see, the list goes on. So you have postural changes, the freezing of gait, and so on. And then there's others here that sometimes we don't think about so much, but Parkinson is complex enough to have non-motor issues as well. So just the fluctuating nature of Parkinson is a true challenge. So if you either on-off phenomena, as I was mentioning with the other gentleman, so it's like the fact that he does not take his medication places him at risk in the moments where he doesn't have his medication doing an effect. He becomes slower, and his step changes, and he starts having freezing in off, and that's why he's falling. Then you can have things like that you might not have thought about, which is constipation. So constipation, how is this a fall risk? Well, basically it interferes with absorption of your medication, and so that will, on its own place, it connects with the same reason. The medication is not being effective, and so all the gait changes occur. And then what you were mentioning before, which was orthostatic hypotension, which means that especially in changing positions, if I know the person really well, sometimes I'll alert them, if you've just had a large meal, which is a very common thing in Portugal. We spend a whole hour eating here in restaurants and sometimes more. And it's hot and people are drinking alcohol, and then they get up and then they might fail. So there's a whole bunch of risk factors here that associated to having an episode of hypertension and being able to fall relate to those moments. And by giving this knowledge to the person, I'm incapacitating them to be alert for this and take measures against it.
And also, if that's something that you are noticing, that it's definitely something to bring up to the doctor, and not the kind of thing I would wait until the next visit, but it would be a my chart question. Hey, I'm having these issues, or the PT noticed it. Hopefully your PT is also communicating with your doctor, because some of that could be related to the medication. It could be related to the amount of hydration. It could be related to other factors that are related to the actual disease. That's why you need to really take an active approach to address it. And Peg, when you're bringing that up, I mean, it's very cogent. It's a very good reason. You're not worrying about falls. You're having something that's on your radar that you should be attending to, and not addressing this, not an option.
The list is enormous, as you can see, and we don't want to get lost in that. We want to be more specific. So if we have someone in front of us, we will try to think about, for this person, what is the potential risk factors that might be contributing to the falls, right? So everyone is very unique. Maybe it's, someone that's not taking the medication. Maybe it's someone that is not recognizing the impact of this case, for example, of the changes that might occur when the person is dividing their attention with another thing as simple as talking on the phone, or, maybe thinking that we can still have our grandkids in that are very big and holding them like you see the gentleman in the middle. But it's just being able to recognize what risks are we taking throughout the day. And sometimes these risks are mostly recognized by the care partners and families. So it's important to include everyone in this. When we think about a different or the next step is really managing those. So we identify the risks, we identify the circumstances, and the challenge is we don't imagine that the person can will need support for this, and because there's lots of details that go into it. And so obviously recommendation of, trying to get either to your movement disorder specialist that will probably focus on, is this a new problem? Is this something that's related to the progression? Is this some changes in medication? So it's important for him to try to understand the reason why suddenly there's a fall or there's falls. And then obviously he will be focusing on the severity, how often is this happening, and thinking about reversible causes. What I tend to say, taking it a step further, the physiotherapist or the occupational therapist might bring a little bit more smiles with solutions. Obviously, we are professionals that are in close contact with the person, and especially if the falls are happening in a home setting, it's very good to have a home assessment, and so that we can explore well where the person is falling. I tend to ask if the person is able to film the situations. That's also very good, so that we can sit down and analyze the movement together. I think that usually works the best. What the physiotherapist or occupational therapist will focus on specifically are trying to understand the location where if you were getting out of bed, the size of your bed, what did you have next to the bed, things that what can we do to be able to change the setting, the environment. What can we do about the movement? How can we convince the person to be able to change? So that is a nice way for us to be able to go forward. But I can also give you some comfort that obviously this is highly researched, and any professional will have access to this type of knowledge, and they will understand that once we identify the risk factor, then we have certain interventions that are recommended, and they will probably combine pharmacological and non-pharmacological strategies. So this, I won't go into detail about it, but it's just identifying what is the risk factor and then what are the interventions that are recommended, and then focusing on that, right? So if I'm falling because my posture is changing, I might consider intervention that will specifically help me improve my posture. So it's not only about balance, right? And then when we think further is really thinking about other things that might be influencing, especially when it's a new problem. It's like, wait a minute, what changed, And also thinking about what makes it worse. Can I identify situations that make my fall worse? So if there is a worsening of anxiety and depression, these are factors, for example, that increase the fear of falling. They have been studied to have that association, specifically anxiety. When I showed you the woman before, it's like the anxiety of the falling, the fear of falling was the one that was the element that is the making her avoid behavior and not being able to feel safe. So can we do something about that if that has changed? And also keeping in mind that sometimes there's acute changes. There might be something that's happening underneath. Maybe there's an infection somewhere, a urine infection or dental infection. And that means that the system is adapting to that, and that sometimes even with prescribed medication will also interfere with the treatment of Parkinson. And so it's what we call crisis situations, that by dealing, for example, with the infection, reducing the infection, you will reduce the fall. Okay, then in the world of rehabilitation, there are very specific interventions, and specifically for a balance and gait, unfortunately, the medication is not as efficacious as we all would like it to be. And so it's areas where we might hear more about professionals like the physiotherapist and the occupational therapist to help you. I want to give you one practical example so that you can see the extent of the intervention of such professionals. This is a fall that happened when the person was going down the stairs. And as you can see, the impact of the fall was significant because this is the result of the head hitting against the wall, right? And so when we look at a scenario like this, it's like, what can we do about the activity itself? And what can you do about the environment? And when we think about this, this is where adaptations we might want to recommend to the person. And on your right is what we call using cueing strategies. So it's not, people tend to fall more in walking forward or crossing the doorway or something than actually stairs, because the stairs there is less cognitive thinking about going up the stairs, coming down. But actually, the moment where people might have more risk is at the end or at the beginning. So it has mostly when the person is changing their pattern of walking is when they more place at risk. And so just by making people aware of that, as you can see, the floor just becomes there's a shift of attention that you have to have on the last step. So by placing some cueing, which means some lines on the floor that highlights this is the moment where you have to be more attentive, could be enough to solve this problem. And I've seen situations where it was enough. Increasing the lighting, okay, the way we adapt the environment. So I just want to give you examples. What we do is just assess the house, and this gentleman put his feet two together. So what we decided was put a line in the middle where I was really trying to reinforce that he puts places one foot on one side and the foot on the other side. So just helping him have a better pattern of movement as he's going up the stairs. We train this. So this is part of the training. This is how we solve this problem. And sometimes I say, oh, no, but I don't want this strategy. Okay, it doesn't matter. We have a whole book of them. So we just keep trying different things. And the brain he adapts really quickly. So we have to always be creating new things. But this is just different ways that you can maybe increase the contrast of your stairs. Again, I'm just using this example because it's actually one of the situations that the care partners refer more, that causes more anxiety, is the person going up and down the stairs. And if everything else fails, then obviously there are ways for people to be able to reduce the risk, but it's very challenging to convince people to actually come to these solutions. Okay.
Someone in the chat was mentioning this, and I think it's great that you're looking at it. I think it's excellent to keep an open mind and see what you can do.
Yes, it's like, but convincing the gentleman to eventually have done this, believe me, it took us a while. And I say us because the wife obviously was into this tragedy. And there's obviously financial issues regarding this. It's not accessible to everyone. The other solution would be that I tried to give to them was just having a room downstairs, but they were so used to having their room upstairs that it was very difficult to change that. So they preferred to waste a lot of money and put this.
Especially when you have one that turned during the corner. That's what pretty expensive.
These stairs are pretty small and stuff. But okay, so I think it's like, don't lose hope. There are strategies and people just really have to be creative. And then obviously I think another key message in just coming to the end here is like, keeping updated with new interventions. So I think in line with don't lose hope because there's always new things, and falls is a topic that has a lot of focus, obviously, because of the impact it has in society in general. So what would be new interventions? This is me thinking about how we always relate falls to balance. So I went and just see, okay, what's new in terms of the rules of balance? And funny enough, there was an outcome now, a paper that was just looking at different types of interventions, and the one that was highest, that was related to the best outcomes for balance was dance. And we hear this a lot. I would say that anything that helps you transfer your weight and also challenging your attention is and physically active, aerobic component. It's just it involves all the components that we need to be able to improve balance, which is a complex, I would say, factor. Lots of things that contribute to it. But so this is the news, and we will actually do a talk later in July regarding the best exercises for balance. So I will come back to this later on. Technology is always improving. So I think keeping really notice about how it can also support us in dealing with this problem is also important.
Yeah, and I think this was a groundbreaking tool when it came out. This is Apple actually had a fall monitor built into their Apple Watch. Now it's available for a lot of them. When any system will have one, but basically you can wait. Oh, did you get rid of that slide? Okay, yeah.
No, there's other.
The other platforms are going to show you that if you don't have to have an Apple product, an iOS product. Although someone in the chat was talking about Room Labs Stride PD, which is kind of a self-reporting symptom tracker that actually ties also with your Apple Watch. And that is only available on the Apple Watch only because the FDA has only approved an algorithm for that product. So there's actually several ones out there, but that Room Labs one is the only one that's free. This is not necessary to have at Room Labs product to be able to get this falls monitoring. But I will say that if you're going to use this, or if you're going to use the version for the Samsung Galaxy or for the Android or whatever, that's fine. But if you're really dealing with this and you need to be able to alert the emergency authorities, you might want a dedicated product like a Sonic, the Philips version, because it might need to be a little more robust. This is still getting better, though. For free, it's pretty good. Let's put it that way.
And it's just an example of how technology can support this. And I think there's multiple other ways as well.
They're going to start seeing falls before the hand, and I think they're going to see hesitations and freezing. It's getting so smart. It's ridiculous. It's crazy.
Yeah.
Artificial intelligence is amazing.
Yeah, I was going to say, AI will bring us more solutions.
Before it takes over us and uses such for fuel for its whatever it is.
And the final thought is obviously, it's not because it's final, it's part of the whole program, which is obviously thinking about the care partners and care partner, because I think this actually impacts more the family. From my perception, seeing it from the outside, and sometimes I'm highlighting to the person with Parkinson. It's just, I know that you are able to do it, but the amount of anxiety that you're causing your wife or your husband, I just want you to be consider that when you go out alone. It's just if we can, negotiate, halfway, and just being attentive, because it's very draining for the family. It's usually transmitted as, I think families usually feel like they failed somehow when the person falls. It's like they in the relief, or at least when I try to share with the family, it's like, if you can get away from that blame, because it's impossible to prevent all falls, right? And so it's important to get to that situation where you are comfortable thinking, I am doing everything that I can, and that should be enough, right? Because it is a complex problem. So I think this is usually the way I would manage a situation of falling, and it's a very common problem that I deal with in clinical practice. Now, so I'm going to finish in terms of thinking what we want to change from the title, which is, are you worried, worrying about falling? And just be very honest to say it is a real problem. So it's a risk. Falls, if people are talking about it, yes, it's because it's important. But I want you to know that we can really reduce significantly that risk once we identify what we are dealing with. Okay, so it's just in general might look hopeless, but it's not. We identify what is the cause, and there's multiple ways that we can approach it. And so I think we should really focus on how can we replace this worry with a good strategy. So now I just want to ask your permission to 5 or 10 more minutes. Why? Because there were several questions that came in the questionnaire that I organized now at the end. And I will quickly answer each one of them, so that I don't want anyone to feel that they sent out a question and it wasn't answered. So one of them was, what does it mean to manage a fall risk? And hopefully with the talk that we have covered, it's really about reducing the impact that it has. Unfortunately, it's not eliminating completely, although there are situations that if we truly identify the cause, it's possible that people stop falling, right? So it always comes back to what is the cause? What is causing the fall? And then we have another question, which is, can fear and discussion cause nervousness with increases falls, which is what we discussed about. One of the concerns that we have is that we are actually enhancing the fear of falling. And this is an issue that incapacitates more people. And so that, yes, you are absolutely right, it can. And so it has to be a useful discussion. Let's try to have less fear of the falling by really talking about how we can handle it. Another question, in physical therapy, is the client trained on how to fall to prevent substantial injury? And I'd say it is recommended in our guidelines. So yes, it's supposed to be. I did put some examples here. This depends on if the person is young onset or not. Like this case, you just take the sound out. Sorry for that. We can have different strategies in the home setting as well. I think the most basic one would be in the home, just teaching the person like, okay, how to get up, try to stay a few seconds in a certain position, try to reach up or something. No, but I don't need to, but I want you to, because, once you get up, you might fall again due to some hypotension as well, or the static hypertension. So here it seems extreme, but if I do have someone with fear of falling or just might have more conservative training of this on just allowing the person to fall, but provoking the falls in a safe way. Not easy to train because we do cause panic, right? If I'm truly pushing someone, I can lead to anxiety and in panic. So it has to be, you have to have lots of confidence with the person, in the therapist that's pushing you. Permission to push.
But guys, she's pushing in there. Did a nice hackathon with Room Lash a couple years ago, by the way.
I frequently feel like I am losing my balance backward and I have limited means of catching myself backward. Any suggestions? So yes, as you can imagine, this could have a whole discussion on this, but I did want to leave you with the tip. If you notice this picture, this is all people with Parkinson and they have something there in common. If you notice, the heels are together. So we do recognize that there is a common pattern of people with Parkinson reducing their base of support. So the space between their heels, I wouldn't even say feet, the space between the heels. And that means that you are challenging your balance even more. And so what would an easy solution be is if you can train yourself to every time that you stop to open up the space between the heels. Now, I will alert you, like you don't have to exaggerate like cowboys or something, because then taking the first step might become difficult. But I'm never concerned that the person's going to exaggerate because the tendency is always to be so together. So just an alert. I think it's a very easy strategy that can help you, give you a sense of balance, and so that you might not feel like you're falling backwards. But obviously, if in other situations where we are dividing our attention with other activities, so in dual task scenarios, keeping just a reference, touching a wall while you're talking to a friend, or just having a stool while you're doing something else, or just touching something is enough to give the brain information about where you are in space, and it will reduce the stress over and the muscles that have to be activated. Okay, one other question was, when I do fall, how should I recover? So trying to understand the question itself. So I'm thinking from the first stage is like just highlighting, especially to the families here and care partners, that the way we help someone get out of a fall, because it's usually a very panic situation. I had this one gentleman that he used to fake falling so that he could train his wife. And it's a very dramatic strategy, as you can imagine, that I disapprove because it causes a lot of anxiety to the wife. But he felt that was one way to train her, and he would say that humorously, in which, people have these behaviors sometimes. So I would say that trying to stay calm is an obvious thing. I was telling the person to stay calm is usually something we don't try. It's just trying to learn ways that you can facilitate the movement, like bringing a chair, assessing if the person has severe pain or not. As I said, if we call the emergencies every time a person with Parkinson falls, you would spend all your time going to the emergency room, unfortunately, because falling is frequent. But it is important to understand and distinguish between a severe fall or not, if there is an injury that will require maybe not moving the person. But again, please reach out to your health professionals because they do treat this and they will focus on helping you get better strategies.
And maybe how to fall better so you're not putting your hand out and breaking your wrist, as someone here put in the chat.
It goes in line with the training of falling and how to fall and reduce the impact.
Yeah.
Okay. And so, yes, I did know that there was a question here related to passing out, which would be
orthostatic hypotension.
this one is really clearly different because controlling this type of falling is more challenging. So if the person before is someone that's dealing with this usually has some symptoms before, either they feeling that they have the room is moving around, or they're not feeling so well. Sometimes the person can perceive the event, small signs, and if that is possible, then it's really reinforcing that when this happened, please sit down. This is what I teach the people that I was like, once you start feeling that, because someone will say to me, no, it will go away, it will go away. But the risk of it not going away is increased, right? So it's just like, please do not pretend that it's a light problem. Falling when you're passing out, that means you do not react. And so the major injuries could be related to this type of falling. So this is the one that we really have to be strong on recommendations of. Just if there's no wall, if there's no chair, please sit on the floor immediately. But again, it has to be assessed to understand why this is happening. So not taking hope away, find out why this is happening, right?
I mean, there can be a lot of
factors. Medication, it could be so many things that could be related.
There may be things you can do to mitigate it.
And then, is a cane as useful as a walker when considering fall prevention? Now we come back to depends on the person, depends on the context, depends if the person accepts a walker. Obviously, when we compare one to the other, one brings more stability.
You have a place to sit with the walker.
It depends on the walker as well, if it has wheels or not, because in Parkinson specifically, people don't like those walkers where you it doesn't correspond to the speed that the person needs. So there's unfortunately, I really have to reduce it to depends on the person.
Worth having a conversation with your own physical therapist and make sure that it's tailored to your needs. Yeah.
I often hear frequently, like the cane, the care partners will say, but he doesn't even use it. He's just holding it, right? So this is, again, because just the sense of having the cane, the perception of safety when I need it, I'll have it here with me. So that is enough to actually help and be useful. Another one, is there a one-size-fits-all device that can address all fall risks? I decided to put this one here. This is a very interesting...
We should have a system where you can strap it.
I would highlight to the person, did you see the list that we have of all fall risks? So unfortunately, the all that we need is all your fall risks, right? So several that might be happening at the same time for that person. I wouldn't say a device, but definitely there's solutions and strategies.
Something with a drone coming.
Yeah. And maybe if I had to choose one device, it would be soft floors in everyone's house. Okay. That would dramatically reduce risks.
Yeah. Right now.
In the houses. The carpets should be nice and fluffy.
Yeah. That's true.
And then I can tell my gait is getting worse. Sometimes I don't lift my feet up enough, causing me to hit the ground too soon and stumble. What can I do? So there's different approaches to this. There's the cueing strategies that we teach to people, cognitive strategies about putting the heel down first, but it requires someone looking at your gait. So maybe a health professional that can analyze your gait and see what specific patterns are happening. So shuffling gait is usually because the person is not putting the heel down first. And so we usually reinforce this in treatment. The problem with the cueing strategy is that the person has to cognitively be thinking about always putting their heel down first. And this is very challenging, especially if you're dividing your attention. So that's where the training comes in. So we reinforce that by training it. And the exercise and the gait training, treadmill training has a lot of evidence for this. But again, to be more specific to you, probably just analyzing it in the video. Okay, and then we're coming down to the last ones. How can I reduce my risk? Are there any exercise specifically for balance? And based on this question, as I shared with you, we will have a talk specifically looking at exercises that improve balance in July. Is there any specific topic that you feel that was not approach?
Questions we can answer.
Fail is a world. So the idea is to be able to guide you in information where you can maybe find the better responses, but to dive into each problem would take too much time.
We'll come back to it again, too.
Yeah, but
All right, everybody. Well, thank you for coming in. Great to see some familiar faces. Glad that some of you folks got to check this out for the first time. Thanks for coming in, everyone.
Thank
you.
Thanks.
Thanks.